Great to have everybody with us today here on the John Fredericks Radio Network. Joining us now is Dr. Andrew Bogan, that's Bogan. He is a scientist. He's in the middle of a study. I'm going to give you his credentials here in 1 second. But Dr. Bogan with us now, just to give you a little background, his mom, Dr. Elizabeth Bogan, was my economics professor when I went to Fairleigh Dickinson and played baseball there in the 1970s. So that kind of dates us a bit, but he's joining us now. Dr. Bogan, great to have you with us.
Thanks very much, John, and good morning.
Give everybody your credentials. You have an undergraduate degree from Princeton. You've got a PhD. Just kind of outline what your credentials are, sir.
Yeah, so I trained as a scientist. I did my undergraduate work, like you said, at Princeton University in molecular biology and bioengineering. And then my PhD research was done at the University of California's San Francisco campus, the UC Systems Medical Center here in San Francisco, California. For most of my career as a biotech investor, supporting businesses large and small in biotech research.
Dr. Bogan, you're a scientist. What got you involved in the Covid-19 study that you've been heading up?
So, John, I've been very interested in viral disease throughout my career as a scientist and also as an investor. It's something I always keep attention to. When I saw a new outbreak of what appeared to be a potentially serious new viral disease in Wuhan in central China, it was definitely alarming to me back in January. Started taking a look at the things I do, genome sequences and case rates, and then sadly later on fatality rates as well. And those were some of the areas of interest of mine. And I started talking to friends of mine here at Stanford University who were working on similar considerations in the epidemiology group at the School of Medicine, and tried to help them with some new ways to think about ways to research this disease and understand it better, because we've really been largely operating in the dark.
Well, and it's a shame because operating on the dark, we've had a lot of flawed models, right? I mean, it started out saying 2.2 million people had died, then would die, then 1 million people would die, then 100,000 to 220,000. Now it was 80,000. Now it's 60,000. So government politicians are making life-altering decisions, Andrew Bogan, for millions of Americans based on what appears to be a litany of flawed models. Tell me the study that you're working on now, what will it reveal?
Yeah, so the challenge with modeling is it's entirely dependent on the quality of your input data. You have good data in, you have a well-built model, you'll have meaningful results. If you have garbage data in, you'll have garbage out. The challenge is really that we haven't understood how many people have actually been infected with this virus so far. So the models have been largely based on assumptions about the fatality rate from this infection, starting with the WHO's estimate of 3.4% and some estimates generally falling between 1 and 3%, that meaning 1 or 2 or 3 out of every 100 people who were infected with this virus would be killed by it. We've been very doubtful that that was really going to prove to be the case when the final numbers were in, but it's been very difficult to collect that broader set of numbers. So that's what we try to do with this study, is to understand on a population basis how many people have actually had this virus so far. And we did this seroprevalence study to determine that here in Santa Clara County, California, or the heart of Silicon Valley. It's about a 2 million person population. We did a sample study of it. We're actually just getting ready to publish those results in a peer-reviewed journal now. But what we're trying to determine is what the ratio of true infections is to the cases that are known. Because there are a lot of reasons people wouldn't know the true range of the infection. Most of the cases we know about are people who are very sick, who came into hospital. And not surprisingly, we've sadly seen a meaningful percentage of those people end up with very bad outcomes, including deaths. But that probably isn't the whole picture of everybody who's had this disease, and that's what we're trying to understand.
When your study, Andrew, is released, when this started out, we were told by some of the modeling that 1 out of every 3 people would be infected. We were also told that we could have dying rates that were up to 5 or 6%. That's certainly what it's been globally. When you're doing this study, so what you're trying to determine is exactly how many people have actually been infected, right, in your modeling, and then of those, how many people are dying. And when you put those numbers in, the way your study is coming out, it dramatically changes the outcome of the model, which should dramatically change the way the government is making policy based on the model. Am I close here?
That's exactly right, John. If you understand the way these epidemiological models work, they're essentially statistical simulations of the input data. And there are two really important pieces of information that get put in. One is the, it's called R naught by the scientists, but it's essentially the number of people who any one infected person will infect. So will you get 2 more people infected if you're sick, or will you get 5? And that's, the concept of trying to reduce contact between people is to try to lower that number. But the real driver of all the models' total fatalities in the end run of their modeling simulation is actually the infection fatality rate. And if you use a case fatality rate, you're going to have a very biased sample of what the denominator of that ratio is, because the true number of infections is going to be much larger in all likelihood than the number of known cases. And there are some specific reasons in the case of this disease that we think that may be a very significant problem. And we wouldn't be surprised to find that the infection fatality rate is actually orders of magnitude, 10 or possibly even as much as 100 times lower than the currently believed case fatality rates that are being used to drive these models, which would really dramatically change the output of the models. And we've seen the modelers start to move from their original, very much doomsday model positions, like we saw with these, 2 million American dead kind of, doomsday scenarios, to numbers that are continuously falling, as you correctly pointed out from what the major models have said. And that's because they're starting to move toward a more realistic understanding of the character of this disease and the degree to which it may already be quite widespread, with many times, potentially orders of magnitude more cases than have been measured. So the true infections number is likely to be much larger than the known cases that was driving this modeling.
You're on the John Fredericks Radio Network. We're with Dr. Andrew Bogan. If you want to look him up, it's Bogan. Dr. Andrew Bogan, he's a scientist, biophysics scientist, has his doctorate from the University of California in San Francisco. If I'm following here, Dr. Andrew Bogan, what you're telling us is that when your study comes out and you took Santa Clara with a 2 million population, you're going to extrapolate from that how many people actually have had the COVID-19 infection, many of them obviously asymptomatic or very mild symptoms.
That's right. At the beginning of the month, we did a population survey where we actually asked volunteers that were selected on to be a representative or as representative as possible sample of the county. And we had a drive-through testing station set up in 3 different locations, geographically spread out across Santa Clara County here in Silicon Valley. And we took just a finger prick of blood from each of those patients and ran it on what's called a serology test or antibody test kit. And what we're looking for there is to see if there's antibodies in the person's blood against COVID-19 virus antigens. And if there are, that means that the person has had a previous infection, 3 to 10 days before or earlier with the virus. And so far, the testing we've all heard about, and we know it's limited, and that's why we think the case numbers are probably wrong, but the testing has been PCR testing. It's been looking for virus genetic material in nasal swabs. So do you have an active infection in your nose of this virus? And what we're looking at is actually a question of, has your immune system already responded to this virus? Are you a previous infection that we might not have known about?
So basically, of the 2 million people in Santa Clara, you took a sampling, a statistically significant sampling, which is then going to give you the number of those 2 million that were actually infected by this virus, which is then going to give you a percentage of the pop, right?
I think it's safe to say that Dr. Sarah Cody and her team that we collaborated with on the study at Santa Clara County Public Health have a fairly good understanding. No number's perfect, but their statistics on the very tragic fatalities that we've seen here in the county, I think can be relied upon with pretty good accuracy. The thing we don't really know is what the denominator is. What's the number of cases? In our county, there have been, when we did the study a week or so ago, there had only been about 1,000 cases detected of active infection. Is the number considerably larger than that? That's what we're trying to determine. And there's starting to be some data coming out from other sources. Some of it in new studies that have been published, others of it in pre-releases of research data that's not yet been peer-reviewed, that would indicate that these multiplier effects, the ratio of actual infections to the known cases might be quite a bit larger than anybody has thought. So there's been some influenza-like illness data that's recently been published showing that if you look at medical records across the United States of people who've come in this sort of late winter into the early spring with influenza-like illness, that this is not really a time of year where you expect to have very high influenza loads. It's actually usually the tail end of the influenza season here into March, and it's usually about petered out by April. And yet we're seeing quite a lot of influenza-like illness being reported of people who are not being tested for COVID at all. And that study suggests that there might be as many as 100 to 1,000 times more people with influenza-like illness than you would normally expect this time of year in the United States. If you go to Europe, there have been some studies that have been a little bit more specific, where they've actually measured infections and then done some analysis of their infection measurements in Iceland to show that about 10 times as many infections are going in undetected as the ones they know about based on their research. And just earlier this week, the New England Journal of Medicine, which is one of the premier medical journals in the United States and actually in the world, they published a study from a group at New York Presbyterian and Columbia University Hospital in New York City, where very smartly those hospital systems were testing every woman who entered the delivery ward to give birth to a baby. So these are pregnant women coming into hospital to deliver babies. They found that 14% of them were COVID positive on PCR, meaning they had an active infection of COVID-19, of the coronavirus. But 88% of those were asymptomatic. And they didn't do any serology or antibody testing like we've been doing, so they wouldn't have known if there were any more people in that 215 of those 215 women who'd previously had an infection and already recovered. So, I'd really say that in that case, the 14% that they see is kind of a minimum number who were just the ones who were actively infected, let alone the ones that might have been previously infected. And of that group that was positive when they came in to deliver babies, 72% of them, so almost three-quarters of them, John, never showed symptoms of viral infection at all. No cough, no fever, no runny nose, no sore throat, no idea they ever had this disease at all. So that's in a situation in New York City where and New York State has done a terrific job of trying to ramp up testing as fast as anybody because of the very serious crisis that they're facing here.
Right.
And, they know of about 1.2% infected. Well, if the true number is above 14%, and I think that data suggests it may be, although there are reasons to think the pregnant women population might have different than the general population, that number would be 11 times. So I think we're starting to see a picture here, and why it's so important to collect the data like I've done with my colleagues at Stanford University here in Santa Clara County to understand on a population-wide basis of a true general population sample of otherwise, healthy people, how many of them have already had this infection? What do the numbers actually look like? And then we can calculate realistic estimates for an infection fatality rate for this disease.
I want our audience to really grasp here the significance of Dr. Andrew Bogan's study. And I'm going to paraphrase some of it, Andrew, so that we can get the totality of it, because millions and millions of lives are now being affected in a negative way by policies that are being brought on us by politicians basing those policies on the flawed models they have. So let me get this straight. In Iceland, they checked pregnant women coming in, and 14% of them had COVID-19. Yet when you look at the New York model, it's like they're saying, well, 1.4% or so are infected. That's what they've tested, but it's actually could be 10x that. On the other side of the scale, everybody that dies that has COVID-19 is put down as a COVID-19 fatality, right? Every single one, even if they died for some other reason, whether it be pneumonia, natural causes, old age, leukemia, whatever. If they had COVID-19, it's put down as a COVID-19 death. So that number goes up, certainly some. But what you're saying is, when your study comes out in Santa Clara, that we could have new evidence that suggests that the number of affected Americans is going to go up by 10 to 50 to 100 times what it is now, which would then make the mortality number, go down by 10, 15, 100x. So right now, if you take the United States, right now, we have 26,000 people who died. We have, in the U.S., about 600,000 people that have been diagnosed with COVID-19, or a 4.3% mortality rate. That 600,000 number could be 6 million, or it could be 8 million, or it could be 100 million, right?
Yeah, we certainly don't know that. I think it's really important to see seroprevalence done, not just in one county, but in as many places across the country as possible. Our colleagues at USC and UCLA have been doing a similar study. They actually just completed a sampling of, I believe, about 1,000 serologic tests in Los Angeles County. We fully anticipate this to be rolled out with our partners. Major League Baseball is cooperating to do enterprise-wide, so not just the players, certainly, but all the employees across the whole business at every level across the country. And we expect a lot of other scientists and public health officials to get involved very quickly here in doing this kind of serology work so we can get these numbers right. Because you're exactly correct. These numbers fundamentally drive the models and dictate the outcomes of the models. The models are very sophisticated and mathematical, but they don't generate reality unless the inputs are real. And we need to get those inputs right, and we need to do it fast. And we're one of the first studies in the world that's already in peer review with a major journal to determine those numbers. But we're already seeing, like I just mentioned from some other sources, early indications that the numbers are, an order of magnitude or potentially orders of magnitude, meaning 10 to 100 times, like you said, larger in terms of the number of actual infections to the known number of cases. And that just fundamentally changes the equation of how fatal this very serious infectious respiratory disease is. And we know COVID is capable of killing people. We're starting to see a better understanding of who's at most risk. And I think we may be able to be much more surgical in our approach going forward as to protect the people better who have the most risk. But we're also now learning, just in the last few weeks, really, John, that there are large percentages of people in these different studies that I mentioned some of. Another example, recently they did 2,000 of the 6,000 residents of the town of Robbio in Italy. They found 13 to 14% were seropositive, meaning they had antibodies against the disease and had a previous infection. That was 30 times the number of known cases there. Italy knew they had a serious problem. It wasn't understudied. It wasn't undersampled. It's that the bias that has gone into determining who has COVID so far has been based on a limited number of PCR test availability, testing primarily the sickest patients presenting with severe symptoms in hospital settings. Imagine for a second if you were trying to understand the fatality rate of car accidents, and you only went and looked at the car wrecks where ambulances have been called, where there was a serious problem. You'd have a much, much higher number than reality because you hadn't looked at any of the fender benders, of which there are far more than there are of fatal or near fatal serious accidents.
Dr. Bogan, let me just ask you one other question because I want to get to the bottom of this, and I know we're a little ahead of the study actually coming out officially. But right now, the published mortality rate for COVID-19 in the United States is just over 4%. Last night at 5 o'clock when I got the numbers by my research team, it was 4.3%. That's a pretty high mortality rate. That gets people scared, right? Look, if I get it, there's a 4% chance I could die. So that's driving a lot of these decisions being made. But that is not a real number because if your study holds, what could that number be? The influenza number of the common flu is 1 out of 1,000 people die of it. It's a tenth of a percent. Theoretically, this 4.3 number could go down to what? A 0.5% under that, right?
Based on the various data I just talked about from other locations, I think that would be a correct conclusion.
So let's think about this a second. If you were doing the numbers and inputting them the accurate and right way for the modeling, that the mortality number for COVID-19, which is right now been hovering about 3.5% to 4% in the United States, could go down to 0.1% or 0.2%, which is exactly the same as the common flu. And so look at the decisions that have been made. We have shut down an entire economy, put what is going to be at the end of this month up to 25 million people out of work, destroyed millions of small businesses, added trillions of dollars in debt, destroyed families, homes, marriages, children. We've got suicides. We've got alcoholism, drug overdoses, all the societal things that come with a family not being able to survive financially, with a mom and dad not being able to provide for their children, all the negative things that go with that, coupled with the fact that 90 million people are employed in this country by small businesses, which are being eradicated, based on modeling that Dr. Bogan is saying could be so flawed that the mortality number could be off by 100x. And look at the decisions that have been made. Incredible, Andrew. Incredible. I can't wait till the accurate study comes out, and I hope we're going to do something with it. I really want to thank you for the work, sir, that you've done and for the time that you've put in, because the ramifications of the politicians' decisions that have been made on flawed modeling that you're on the verge of exposing, if you will, is catastrophic, Andrew. Am I right?
I don't disagree with your concerns. I think it's important to always point out that when the decisions to do very rigorous measures across the U.S. and around the world were made, they were made in the absence of this data. They were made in the dark. And, we're scientists and clinicians on my team. And what we're trying to do is to do the science, to collect the data. Good policy decisions are based on good scientific data. And if we can provide better data to inform better decisions, that's always our goal.
Well, certainly your study should be looked at, reviewed, and implemented when it comes out immediately, so that better political decisions that affect millions and millions of people can be made. Dr. Andrew Bogan, I want to thank you for your time today. Fantastic. I really, really appreciate it. Thank you for explaining it, sir, in detail.
Thank you, John, and
we'll
thank
have
you
you
to your
back.
listeners, too.